The cardiac arrest circular algorithm guides providers on the correct procedures to providing high-quality cardiopulmonary resuscitation. It begins after recognizing that a patient is in cardiac arrest, no pulse and no normal breathing. The first step is to provide chest compressions with ventilations. In the hospital setting or during a paramedic rescue, essential equipment will be available for use. This involves oxygen delivery equipment and positive pressure ventilation devices, such as an oxygen tank and a bag valve mask device. Another essential device is a manual defibrillator. The manual defibrillator is applied to the patient as soon as possible, being careful to minimize interruptions in chest compressions as it's being attached to the patient. Once connected, perform a rhythm check immediately. If a shockable rhythm is present, charge the device. While charging, chest compressions and ventilations resume. As soon as the device is charged, clear the patient and shock. Immediately perform 5 cycles or 2 minutes of high-quality CPR after shocking the patient. The healthcare providers must utilize this essential equipment immediately during CPR. Keep in mind the key actions. 1. Early diagnosis of cardiac arrest. 2. Immediately performing CPR. And 3. Immediate defibrillation. Push hard and fast in the center of the chest. To initiate CPR, provide chest compressions. Use the two-handed technique and remember to push hard and push fast in the center of the chest. Chest compressions are applied to the lower half of the sternum. Depress at least 2 to 2.4 inches, allowing for full chest recoil on the upstroke. Provide chest compressions at a rate of 100 to 120 per minute. Positive pressure ventilation. When using a bag valve mask device or other barrier device to provide positive pressure ventilation, provide 2 breaths after sets of 30 chest compressions and provide 100% supplemental oxygen. This is performed for 2 minutes. During this time, always ensure that high-quality CPR is provided. Make adjustments as needed. Ensure that compression depth, full chest recoil, and compression rate is being followed. When providing ventilations, ensure that there is a visible chest rise as each breath is being provided. This is an indication that adequate ventilations are being given to the patient. Pulse check and rhythm check. After 2 minutes, perform a pulse check and a rhythm check. If there is no pulse, but a shockable rhythm is present, clear the patient and deliver a shock. At this point, the rescuers must switch places. This is done to prevent rescuer fatigue. Studies have shown that once a rescuer feels strain and fatigue in the arms, the quality of chest compression decreases. Resume chest compressions and ventilations immediately after giving the shock. Intravenous medications. Epinephrine. Repeat the circular algorithm. Consider gaining intravenous or intraosseous access for epinephrine. Once access is established, give epinephrine 1 mg intravenously at a dilution of 1 in 10,000, followed by a bolus 10 ml normal saline flush every 3 to 5 minutes. It is recommended to elevate the extremity where the IV access is in place while administering drugs in cardiac arrest patients. Also, administer the drug with chest compressions. These actions facilitate the flow of the drugs to the central circulation. Intravenous medications. AMIODARONE. If after 3 shocks have been given and the patient remains in a shockable rhythm, AMIODARONE is initially given at 300 mg intravenously, followed by a 10 ml normal saline flush. Again, elevate the extremity and continue with chest compressions when giving these drugs to facilitate transport to the central circulation. Subsequent doses of amiodarone can be given but at a lower dose of 150 mg. Airway management. Consider inserting an advanced airway, such as endotracheal intubation, with quantitative waveform capnography. Once the endotracheal tube is inserted, asynchronous ventilations can be performed. This means that while performing uninterrupted chest compressions, give 1 breath every 6 seconds timed at full chest recoil of the chest compression phase. Quantitative waveform capnography can be used to assess CPR quality. If the measured end-tidal partial pressure of carbon dioxide concentration is below 10 mm of mercury, then CPR techniques need improvement. There could be a problem with chest compressions and ventilation. The favorable outcome in providing high-quality CPR is the return of spontaneous circulation, ROSC. The heart resumes a perfusing rhythm at this point. ROSC is confirmed if a pulse and blood pressure is present. Quantitative waveform capnography will show an increase of partial pressure of carbon dioxide concentration to more than 40 mm of mercury. Reversible causes of cardiac arrest. If high-quality CPR cannot produce ROSC, then the rescuer must think of underlying causes of cardiac arrest, which when addressed can reverse the cardiac arrest. Recall the H's and T's mnemonic. The H's are hypovolemia, hypoxia, hydrogen ion excess, acidosis, hypoglycemia, hyper and hypokalemia, and hypothermia. The T's are tension pneumothorax, tamponade, toxins, and thrombosis, pulmonary or coronary. Refer to the H's and